Good morning, friends. Myself, Dr. Parimal Gharia, a consultant urologist, Icon Hospital, Surat, and I thank PNL community for inviting me for this presentation of PCNL. I would be talking about PCNL, simplifying an enigma. PCNL is the most commonly performed procedure across this part of the world because of high stone burden, but it is still the most discussed or most debated procedure from OR to OPD to podium to social media platform. Why it is so? It is because it's an enigma. So PCNL basically consists of proper selection of desired calyx, a proper puncture of that desired calyx, the proper alignment and proper size of the tract, proper number of the tracts, and ultimately the exit strategy. So what is an ideal renal puncture? The ideal renal puncture should traverse through the cortex to the tip of the calyx. The puncture should not travel through the infundibulum or a major vasculature of the renal tissue. The puncture should not injure any surrounding organs like pleura, spleen or a colon. The puncture done through the tip of the calyx or a tip of the papilla doesn't hit the major vessels, and the likelihood of bleeding through this type of puncture is very less. But what we see on ultrasound or a CM images are the 2D images, and ultimately we have to puncture the kidney into a 3D. So the proper orientation of 3D anatomy of calyceal system is must for proper puncture and proper PCNL. So how to select a desired calyx of the entry? The desired calyx of the entry should give us a maximum stone clearance with minimum risk to surrounding organs like colon, pleura or spleen, so that a single puncture can remove the maximum bulk of the stone. The most commonly performed puncture into the prone position is a posterior calyces, because posterior calyces provide direct access to most part of the PC system with minimum torque. It is easier to puncture by any technique you are comfortable with, like bullseye, triangulation or a freehand techniques, and most of the tracks are through the avascular plane. So what is an avascular plane? We know that the blood supply of the kidney is a segmental blood supply. The anterior segmental artery provides blood supply to most of the part of the kidney, whereas the posterior segmental artery provides to a posterior segment of the kidney. So there is always an avascular plane between an anterior and posterior segment artery circulation, and this plane was actually exploited in an anatomic nephrolithotomy. So in a kidney puncture or in a PCNL, we would like to explore this puncture, and we would like to enter to the avascular plane, so that the chances of hitting a larger vessels decreases and chances of bleeding during the PCNL decreases. Why we desire to enter into the posterior calyces compared to an anterior calyces? The posterior calyces, when we enter the tract through the posterior calyces, likelihood of our wire going directly into the PC system and to the ureter are very high, and so that the wire provides stability for dilatation, whereas when we enter into anterior calyces, the anterior calyces wire curls up and doesn't give that stability to puncture or dilate that tract. The anterior calyceal entry is only desirable when there is an isolated anterior calyceal stone, and likelihood that from the posterior calyceal entry we will not like to enter into the anterior calyces. Though the arrangements of anterior and posterior calyces has been divided into a Brodel type or a Hudson type or whatever type of anatomy we are talking about, but ultimately in the real life it doesn't follow the rule. It can be either of mix of anything. So we need to have a proper orientation of anterior and posterior calyces in the kidney while doing a PCNL puncture. So how we select a posterior calyceal puncture? When we do a contrast pyelogram, usually the posterior calyces are the calyces which are having a faint contrast, and it usually fills later, where the anterior calyces fills earlier. The posterior group of calyces are mostly the medial ones rather than the lateral ones. You can see that the commonly what we observe is when we do a puncture or a RGP in a prone position, there are two anterior calyces in the lower part of the group and one is a posterior calyces. We need to enter through that posterior calyx if we are entering through the lower calyx. But when we are planning to puncture the upper calyces, there are two posterior calyces and one anterior calyces. In that cases, you would like to enter through the lateral posterior calyx. Another trick to get a posterior calyx orientation is to put an air contrast pyelogram. You first and put a contrast into pelvic areas system, and at the end of that you put some amount of the air, so that amount of the air will delineate the posterior calyx and you can puncture that calyx better. The posterior and anterior calyces orientation also can be get by moving the C-arms towards the surgeon or a craniocaudally. Next part is the alignment of the tract. The proper alignment of the tract to the infundibulum of the desired calyx is important, because only when the alignment of the tract is proper, then only we can enter from one calyx to another calyx, and the major part of the stone can be removed by a single tract. Non-aligned tract can be useful only for a single calyceal stone, and from the non-alignment tract it is very difficult or impossible to enter to the another calyces. So the alignment of the tract is important. You can see in this film the upper calyx, middle calyx or lower calyx. All the three entries are shown, but the alignment of the tract is with the all three infundibulum. So whenever you want to enter into the upper calyces, it should align with the line of that infundibulum. Why we are very much concerned about non-alignment of the puncture? Because a non-aligned puncture will give a torque. The excessive torque will damage the kidney, and this damage is usually not seen during the surgery, because this damage or this compression of the parenchyma is occurring outside our vision, outside your implant sheath. So it is always desirable to have an alignment of the puncture. Second thing about non-aligned puncture is, we all know that the renal artery and its branches are the end artery. So whenever we do a non-aligned puncture or a cross calyceal puncture, we are likely to damage some part of that vasculature, and some part of the kidney may become avascularized by this method of puncture. So the non-aligned puncture should be avoided as far as possible. But it is always possible to do a aligned puncture. Sometimes in a special conditions, when we want to avoid the supra-11 puncture, we may have to do a non-aligned puncture. Likely in this case, there is a large stagon calculus, and the upper calyceal group of calyces are above the 11th rib. So if you want to remove the stone from that part of the segments, in that case we may have to do a non-aligned puncture. You can see that the two punctures are made which are non-aligned to the upper calyceal infundibulum. Non-aligned tract can also be useful for an isolated calyceal calculus. Like in this figure, if the stone in the middle calyces, we can do a directly non-aligned puncture in that part of the kidney and remove the stone, because we want to avoid the supra-11 puncture. Same is happens with the calyceal diverticulum calculus. If there are a calyceal diverticulum calculi and we want to remove that calculi, and our puncture in the direction of the infundibulum is going above the 11th rib, we may do a non-aligned puncture with slight increased risk of the bleeding. So now we come to the proper selection of the puncture site. How we do select a puncture site? We have a desired calyx of the entry. So the desired calyx of the entry becomes site A. Now we need to decide about the point B. What is point B? Point B is the skin entry site. So how we decide the skin entry site? The skin entry site can be decided by a conical projection of that calyx onto the skin surface. If we think that there is a conical projection of that calyx onto the skin, then it becomes circle C, and anywhere from the circle C you can enter the tip of that calyx. So the puncture is at the tip of the calyx, and alignment of the calyx is also made. This is a conical projection of the calyx. The conical projection of the calyx to the skin, and you will have a round figure where you can puncture anywhere in this puncture, here, everywhere, but you can always enter the tip of the calyx. So now what we have decided is that decided point A, and now we will be deciding about the point B. So while deciding the point B, we need also to take care of anteroposteriorly direction of the calyceal puncture. You can see that all the three needles are pointing towards the tip of the lower calyx, but only the alignment of the middle tract is according to the principle of alignment of the tract. Now we already had a decided point A, now we have a decided point B. Now you can enter anywhere into the circle C and hit the calyx at the point A. So how to do puncture? While doing a puncture, we advance the needle in a 0 degree towards the point A, and we will try to hit the calyx. Now the depth of our puncture should be assessed in a 30-degree cephalocaudal or towards the surgeon. The trick about assessing the depth of the puncture is about observing the tip only. Like if our needle tip is at A1 and our desired calyx is A2 in a 30-degree position towards the surgeon or a cephalocaudally, then your needle is superficial to the desired calyx. You have to come out and again enter at the point A2, like that is a deeper plane. If your needle tip is below the targeted calyx like A3, then you have to come out and go superficial to achieve the puncture at A2. So the depth of the puncture is assessed always in the 30 degrees towards the surgeon or a cephalocaudally. Second part of the puncture is the skin entry. Some surgeons may enter very medially, some surgeons may enter very laterally. So what is the logic behind this? Now you can see in this figure that there are 3 tracts are made, tract A, tract B and tract C. All the 3 tracts are entering at the tip of the calyx, but the tract A is medial, tract B is in alignment with the infundibulum of the posterior calyx, and tract C is a slightly more anterior puncture. So what we achieve by these 3 tracts? The more posterior or more medial the puncture is, there are less likelihood of entering into the colon. More lateral or a more anterior the puncture is, the more likelihood of hitting the colon. So whenever we made a entry into a bullseye technique, the bullseye technique punctures are more likely to be at like tract A or either sometimes medial to the tract A. When we do a puncture in the biplanar technique, your chances of getting a puncture as at tract B is increases. Tract C are the punctures most commonly used in a supine position. When we do a puncture in a supine position, our tracts are mostly tract C. Here you can see that 2 different surgeons has done a puncture into the same calyces according to their puncture or their preference of skin entry. You can see that the yellow needle is a medial puncture, whereas the pink needle is at a more anterior puncture. The more posterior the puncture is, chances of hitting the colon are less, where if the puncture is more anterior, chances of hitting the colon are more. So you can decide the skin entry mediolaterally according to your preference and your training. You can see how we are making the puncture in this tract. Now the CM is in 0 degree and our needle is gradually advanced towards the desired calyx. Now you can see there is an indentation of that calyx. Now calyx is indented and there is a sudden give way. At this point we know that we have entered into the desired calyx. Now we pass a guide wire and do a tract dilatation. Tract dilatation can be done in a single step dilatation, or tract dilatation can be done with a Alcan telescopic metal dilator. I usually prefer Alcan telescopic metal dilator for tract dilatation 20 French or more. For a mini perc, I use single step dilatation. When you do a ideal puncture or if your tract is exactly at the papilla, you can see the splits papilla sign. The papilla is not meshed up, but the papilla just splits up. You can see the papilla is exactly splitted at the puncture site. This was a case where I have done a check RIRS after 15 days of PCNL, and you can see that the tract is exactly at the papilla of the calyx. This type of punctures never bleeds, or you can say that the chances of bleeding complications from this type of tract is very less. Now we will discuss about the supracostal punctures. Why the supracostal punctures in prone PCNLs are desirable? Because in a prone position, the kidney's position is like that your whole pelvic system is in alignment of that tract. So the chances of removing maximum stone from a single puncture increases with the supracostal punctures. Many people are very fond of supracostal punctures because it gives access to most part of the PC system. But the supracostal punctures also come with the risk of injuring the pleura and resulting hydropneumothorax or a hydrohemothorax. The supracostal punctures are basically divided into 2 parts. One is the supracostal punctures or intracostal punctures. The supracostal punctures are the tract which are aligned to the upper calyx infundibulum. This type of the punctures give access to most of the part of pelvic elastic system, but the chances of pleural injuries are more by the supracostal puncture, whereas intercostal puncture is a non-aligned tract. The needle is advanced between 11th and 12th rib in a cross directions. Though this type of the punctures give access to a particular calyx of the stone, it is very difficult to move from one calyx to another calyx if you do an intercostal puncture. And second, as we discussed earlier, the non-alignment of tract, there are chances of injuring the major vessels or part of the kidney becomes avascular by this tract. So, though the intercostal puncture decreases the pleural injury, intercostal puncture should be used very judiciously in a special circumstances only to avoid bleeding complications. Subcostal punctures, like punctures below the 12th rib and hitting the upper calyceal stone, should be avoided because it is a cross parenchymal puncture. Chances of bleedings are very high. You can see that the supracostal punctures are the punctures between 11th and 12th rib, whereas the intercostal punctures enter from the lateral side of the kidney, avoiding the or a supra 11th puncture. There is a difference between supracostal, intercostal and subcostal punctures, and we already discussed this. So whenever we do a supracostal puncture, we always feel a dilemma that which calyx should be the entry calyx. There are, as we discussed earlier, there are two group of calyces in the superior calyces. One are the medial calyces and one are the lateral calyces. So one is puncture is like supracostal puncture A, whereas another puncture is a supracostal puncture B. The chances of hitting the pleura are almost 6 times more in a type supracostal puncture A in compared to supracostal puncture B. So whenever you take an entry into superior calyces, it is desirable to enter a lateral group of calyces rather than a medial group of calyces. Only exception to this is when you are doing horseshoe kidney. The horseshoe kidney, the tract alignment is such that you have to take a medial puncture. But in horseshoe kidneys, the kidney normally lies below the normal position. So the chances of hitting the pleura are less, and the tract alignment in horseshoe kidney is preferable to puncture into the medial calyces. Then comes the Y puncture. What is the Y puncture? Y puncture is where the skin entry remains single, but we made a two different tract into the kidney. Y puncture can be either it can be in a parallel calyx anteroposteriorly or it can be cephalocodally. In both the cases, the skin entry remains same and we made a two different puncture into the two calyces. Parallel calyces is the situation where you will require a Y puncture because you cannot enter to a parallel calyx from the posterior calyceal punctures. Next discussion point is the size of the tract. The principle is that we cannot remove the fragment which is larger than the infundibulum diameter. So even if you have made a 24 or 26 French, if your infundibulum is 18 French or 20 French, you cannot remove that much size, the large size fragments that matches your amplastic. So in these cases, even though the larger tracts are made, they are of no use. Size of the available nephroscope is also a determining factor in determining the size of the tract. If your available nephroscope size is 22 French, you have to dilate the tract up to 24 French minimum. If you have available mini scope, then only you can dilate according to the infundibulum size and remove the stone from the mini tract. You can see that the upper calyceal infundibulum size is very less. In that case, there is no point in dilating more than that tract. So if you are desired calyx of entries in upper calyx in this system, you should keep your size of the tract to bare minimum possible. If you try to enter this kidney from the lower calyces, you can have a bigger dilatation, a bigger amplastic and a bigger nephroscopes. The second advantage of decreasing the size of the tract is you have a more margin of error available. If your calyx is large and you made a smaller tract, you can enter in a different area of the same calyx, but still that your puncture will be the transpapillary. Another point in favor of a smaller tract is that smaller tracts allow you to have a better interpelvic calyceal mobility. Like in this case, if you enter from the lower calyx, your amplas is fixed to the infundibulum of that calyx and entering into the different calyces become difficult. But if your tract size is smaller than the infundibulum size of the calyx, then there is a better interpelvic calyceal system mobility is available. And we all know that the smaller size of the tract makes less damage to the kidney than compared to a larger size tract. Now you can see this is a pediatric patient, and this patient is having a 16 stagon stone bilaterally. These stones were cleared by multi-tract PCNL. Though the multiple tracts are made, the tract size is limited by the size of the kidney and the size of the infundibulum. You can see the tract dilatation was 20 French, 15 French and 15 French only. Second case I would like to highlight is a multi-tract PCNL. You can see in this kidney that 4 tracts are made. 2 are the larger tracts, 2 are the smaller tracts, but all tracts are in alignment of the calyx. And second point in this case is this is a partially a radiolucent stone. Whenever you are doing a PCNL in a faintly visualized stone or a radiolucent stone, it is better to puncture all possible calyx of entry and park a wire in that. As we go on removing the stones, and as and when required, we dilate the tract. In this case, a large stagon can be removed by multi-tract PCNL. Whenever you see a large burden stone, try to decide entry calyx which will give maximum bulk in a single tract. You can see that the large stagon stone is there, but we can see that the lower calyceal tract can reach up to all the pelvic calyceal system. In that case, a single lower calyceal access can be done. Point I would like to highlight is here is that you can see that whenever you see on CT IVP or a plain images lower calyx to the upper calyx, if you can draw a single line and the stone burden lateral to these lines are less, in that case you can do away with the single puncture even if there is a stagon stones. Second advantage of a smaller tracts is smaller tracts provides better virtual suction, or what we call as a Venturi effect. So when you are doing a PCNL with the smaller tracts, the stone fragments comes out with the flow of the fluid, and you don't require the forceps or the baskets. Decreasing the passes for basket and stone, you decreases your surgical time. Till time we have discussed about the multi-tract PCNL, but remember, one puncture is one PCNL. So if you are making a 4 puncture in the kidney, it is amount to a 4 PCNL. If you have an availability of flexible nephroscope or a flexible ureteroscope, you can think about decreasing the number of the tracts. Like in this case, this was a large stagon stone with multiple stone into the upper calyx also. In this case, we have entered the kidney from the lower calyx, the lower tract is dilated, and there were residual stone in the upper and middle group of calyces. In this case, we have used a flexible nephroscope. This available nephroscope is 13.5 French nephroscope. This can enter into the mini purse sheath easily. We have used that cystopnephroscope, enter into the different calyx and remove all the stone from the lower calyx. You can see how the flexible nephroscopy is used to remove the stones. The entry, as discussed earlier, the entry was in the lower calyx and there were multiple stones in the upper calyceal group. These stones were removed by using a grasper or a basket from the lower calyx. And if your stone in the upper calyx is more and if you cannot remove that stone with the basketing, in that case you can always use a laser, make the stone into a smaller fragments, and these smaller fragments can be removed by the basket. So totally avoiding a supra-costal puncture. In the case what we have discussed, the upper calyceal entry was supra 11. So in that case we did not attempt any superior calycis puncture, removed all the stone from the single lower calyceal entry. The PCNL was done from the lower calyx and the few fragments were seen into the medial calyx. Now a flexible nephroscope was used to remove this residual stone from the middle calyx without additional puncture. So a smart use of flexible nephroscopy can decrease the number of the tracts and may save a puncture and tract dilatation. From the flexible nephroscope you can enter all the pelvic calyceal system and check for any residual stone in any of the group of the calyces. Now comes the exit strategy. I practice tubeless PCNL. Most of the tracts, even if the tract is a supra-costal puncture, I would like to do a tubeless PCNL. You can see that the lower calyx puncture was made and the exit was done without putting any nephrostomy. So what are the indications of tube in my practice? I do put tube only in a cases where relook or a second stage is planned or intraoperatively finding a turbid urine or a infected urine, in that cases I would like to put a nephrostomy. So ultimately in a PCNL, we should try to minimize the risk. How can we do it? By selecting a proper calyx of entry, by selecting a proper alignment of the tract and the proper size of the tract. We should try to decrease the number of tract as far as possible. Do not afraid to puncture an upper calyx and try to avoid unnecessary nephrostomies. Thank you.